So South Africa has logged 305 more infections alongside 48 more deaths, and all of this in the last 24 hours. It also comes at a time where 33 hospital admissions were logged. Meanwhile, the test positivity rate is at an all-time low, roundabout, loosely speaking. It's hovering at around 0.9%. Health Minister Dr. Joe Phaahla says while a fourth wave of infections is expected by next month, higher vaccination rates would reduce its impact. Acting Executive Director of the National Institute for Communicable Diseases is Professor Adrian Puren. He joins us now via our video link. And Professor Puren, always great chatting to you. Thanks very much indeed for making time. Let's perhaps begin by just getting your thoughts around the trajectory of COVID-19 in South Africa at the moment. I get a sense that by now there had kind of been expectations that there'd be a whole lot more infections we are seeing. Are you at all surprised by what we're seeing taking place on the ground?
Yes, I think that's actually very beneficial, I think, for us as a society as a whole to see that the numbers are coming down and reaching such low levels of positivity. We've not seen that level of positivity in neither the first or second resurgence, so this is good. It will be great to think that we could sustain that if going lower, but of course, as the December-January period comes along and as people start moving and coming into contact with each other, the likelihood of increase in cases may well arise. I think what will be very important, though, is that I think that the various departments of health nationally and as well as provinces are obviously going through their phases of preparation in terms of really preparing for that. But I would like to see a disjunction or a separation of, we may see an increase in cases, but the levels of severity of cases, hospitalizations and deaths should actually decrease. So it's going to be very difficult and tricky to really say what the so-called fourth resurgence will look like. It may vary by province, and hopefully be at a lesser extent than that we certainly saw with this third resurgence.
You've precisely preempted my next question, actually. And so perhaps let me ask it this way. What do we know about what the wave might potentially look like in the absence of any new variant? And I'm asking this on the back of the fact that the third wave, we were told, was a whole lot more severe because of the Delta variant, which A, hadn't been anticipated, and B, was a whole lot more infectious. Crossing fingers, hopefully no other variant comes our way. If we've accepted that there's going to be a fourth wave, do we imagine the peak to be much lower?
I think in all likelihood, I think one would hope to think that given the extent of this particular wave, in other words, there'll be a large number of individuals that have been infected and have a degree of immunity, as well as the fact that we have been vaccinating, maybe not to the extent that we would like to have seen as a country, but I think all those particular factors may well contribute. And as you said, quite rightly, keeping the Delta variant as as a constant, then we do not expect to see a resurgence as we've seen in the third wave. But of course, if things do change, but my sense at this point is that we've not seen other variants, at least in circulation in South Africa, that will actually outcompete the Delta variant. So we should see a very different fourth resurgence.
Yeah. Lessons we're learning from the global north. I mean, part of the advantage that we have is that it almost felt like we're lagging behind, even when it comes to the trajectory of our pandemic. They've got a dynamic that's interesting for two reasons. One, a whole lot more people have been vaccinated, and those individuals have been vaccinated for a much longer time. What are you seeing and learning about the ways through which resurgences are taking place in those regions?
Yes, so I think that's very interesting. I think, and again, it's a mixed bag in the United States, and that's because of the differences of approaches in the United States, whereas I think in the UK there has been a great deal of vaccination, and that you can really then see that difference. I know that the hospitals are still under pressure, but my sense is that there is that, as I said, that disjunction in that you're seeing cases. However, the degrees of hospitalization and so forth are very different. In addition, as you know, those particular countries such as the United States, the UK, Israel are good examples, have also introduced a booster as well. And we certainly haven't gone that route in toto, but certainly our focus now is on ensuring, especially the healthcare workers, receive a booster vaccine. So I think the Sazonke trial continues, in other words, enrolling individuals to provide the healthcare workers with a booster. And my sense would be that that will then surely be spread to other individuals once we know what the extent of reinfections are or breakthrough infections are, in order to ensure that we still have high levels of protection and still lessen the pressures on hospitals in terms of the ICUs and oxygen and bed capacity.
Yeah. How effective, Prof, are things like booster shots in a context where not enough of the population has been vaccinated, which is kind of the prospect we're looking at in our context here in South Africa?
Yeah, so that's why I think we really need to focus on trying to have the largest number of people being vaccinated, especially in the older age groups, 50 and above, and especially those individuals with comorbidities. And of course, in the case of individuals who are immune compromised for whatever reason, to actually have their vaccine, and in the case of the Pfizer, to have both the initial and the booster. I think that's really critical. I see that the Department of Health, just looking at their portal, have now started to try incentivize individuals, sorry about the word incentivize, but trying to really encourage people to come and be vaccinated by offering specific vouchers or transport and so forth. So I think those are all really critical in order for us to vaccinate as much as possible. Again, the idea of 67% or 70% of the population being vaccinated was a particular target under particular conditions, but given the nature of the Delta variant and given the nature of the vaccine effectiveness, that figure is much higher than what we expected. So I think we really need to encourage people to vaccinate, especially now in this period where we have such low levels of positivity. This is the time to really get everybody queuing up correctly, wearing their mask, but being vaccinated.
Yeah, yeah. Hard to believe that the issue of inoculation is still such a contentious one, and it has been since it actually came into the public domain. But among the things being ventilated, at least from conversations I've come across, is around how long vaccines are effective for. I think efficacy, or you'll have the right term, but essentially even scientists weren't really sure when next we might need to actually take another COVID-19 vaccine, even for those who are fully inoculated. How close are we to answering that question?
Yeah, so in terms of vaccine effectiveness, so that's what some studies are being embarked on in South Africa to answer those types of questions. We've again seen we have a good sense, and I think that's what that's what initiated some of the debates around the boosters, for example, in the United States and the UK, was in fact when they did look at vaccine effectiveness, and especially for J&J and then Pfizer, did certainly note a decline in terms of infection, certainly. However, there was still a degree of protection against hospitalizations. Nevertheless, I think the thought was, well, given that we have vaccines, given the science, we need to actually introduce boosters. So I think a similar principle will certainly apply in South Africa. I know that there are subtleties in terms of the vaccine regimens and so forth, the spacing and so on. But I think the general principle still remains that there will be a certain degree of vaccine effectiveness that will decline, let's say after 6 to 8 months, that will require additional boosters. But again, I think we will have more and more information coming along, whether or not that spacing is 6 to 8 months for boosting, or is it a year or 2 years. I think more information will come along to assist us. But I think the first part for me still is to try and encourage everyone who's not been vaccinated to be vaccinated.
Absolutely.
And even if you had the infection, I think as well, I think there's great evidence now to show that individuals who've been infected and then had a vaccine, the boosting there is also great, if not as good as being vaccinated in terms of a prime and a boost vaccine.
Right. About that, to be clear though, you still need to wait a couple of days, right, after being infected before getting the vaccine. Absolutely.
Absolutely. You can certainly have a space, but again, if you know that you've been infected, but you haven't had your vaccine, and it's above, I think it's 20 or 30 days, I can't remember what spacing they recommend, but if you have had that infection, and you're ready to be vaccinated, I really would encourage you to be vaccinated.
My last two questions, and I'm going to ask it all in one, so please do bear with me. One, when do we expect the fourth wave? Are we any clearer to knowing when that will happen, given, I guess, the surprises we're seeing, even with the trajectory as it stands? The second question is around the candidate of vaccines we currently have at our disposal. Up to now, we have vaccines that, yes, prevent severe illness and death, but don't necessarily prevent one passing on the virus. So are we any closer to getting to those candidates of vaccines that will enable us essentially to stop passing on COVID-19 after being fully inoculated?
Yes, so those are two important related questions in a way. I think the first one, I think it's really difficult to predict. I'm hoping that the modeling consortium will be able to release its particular results to take us out of our misery in terms of what the projected times. Remember, these are projections, they're not crystal ball thoughts. So possibly, January, February possibly as well. We may see some, as I said, it depends on what's going to happen in terms of the movement and contact of people over the next few weeks. I don't think we've seen any major changes post the elections, for example, but I think it's now really the December period when we have greater mobility. So perhaps later after December, January, we may see spikes. But again, I think our sense would be that it may well be heterogeneous and it may well be different. Coming to your other point about the candidate vaccines that we have here, so I think we need to accept that, yes, we're going to have so-called breakthrough infections, but the level of transmission certainly will occur, but not to the extent that we think. It will still be, I think, significantly effective in terms of transmission. So I think surprisingly, I think those vaccines have shown a decrease in transmission from person to person. I think that's a good thing. But I'm sure that as vaccine studies are refined and candidates defined, I think then reaching so-called sterilizing immunity, I think, is really a difficult one, especially with respiratory viruses. So I think we may still see levels of transmission occurring, but hopefully sufficiently effective not to be a major contributor. I think what was key, and I think that's important, and I come back to that, is when we look at the hospitalizations and deaths. I think that'll be the critical part for us to be able to monitor, to really show that these vaccines are effective.
Professor Adrian Puren is the acting director at the NICD. Once again, Prof, always great chatting to you. Thanks very much indeed for making time.